Hello all. I just wanted to start off with a bit of a statement about a verse that in the land of the blind, the one-eyed man is king. It's something that I've been learning over the last 2 years in my role as a whole of health lead at Shoalhaven Hospital. I think one of the things is that we all experience is that we struggle to understand why our performance is the way it is. We definitely don't like to be held accountable for things that are outside of our control, and we all want to do the best we possibly can in our roles. And I'm going to talk about how we're using daily ETP reporting to drive clinical practice at Shoalhaven Hospital. So Shoalhaven Hospital is in the Illawarra Shoalhaven. It's quite a large population and quite a diverse community. We have 71 to 88 ED accessible beds, and we have 105 presentations a day, 19% admission rate, 5 theatres of critical care. You can see the rest. What we don't have is an ESA or a medical assessment unit. 2 of our other sites do, but we don't. Some of the performance data we've seen this year is that we've had an increase in our ETP. We've had an increase in our transfer of care, quite a significant one. We've done a lot of work on that. And a decrease in our did not waits left at own risk, and a decrease in our ED average length of stay. And I know they're all numbers and performance data, but the translation is that our patients are hopefully getting better care. So we had executive rounding, and I'm sure that happens in many other hospitals, that we did every day for 2 years that I was in this role. It was a bit of a groundhog day. We would go to the same place, talk about the same things, not necessarily move forward. We also had a report that we would use in this rounding that was not particularly diagnostic or meaningful. It wasn't reliable. It would report on delays that often weren't the actual delays, and when we went back and actually delved into the patients that had recorded delays, it was far from what was the issue or the main one. So it wasn't really meaningful, and it was only ED specific. So we decided we wanted to rejig our executive rounds, and we started having a meeting before the executive round meeting. So it was the entire executive team at the hospital would meet for half an hour before going out for a round of around half an hour to an hour sometimes. And we wanted to be more planned, targeted and strategic and specific about what we talked about in each of the departments. But we found we had a lack of information. We didn't have a tool that was fit for that purpose, and it didn't talk about the whole of hospital, even though we would visit the inpatient wards as well as the ED every day. The information that we had to do those rounds didn't have any information that related to the back of house. We also found that a lot of the time the evidence that we didn't have any actual evidence. It was all around anecdote that we were talking about, and that the ETP wasn't necessarily owned by anyone else but the emergency department, and so we took some steps to try and carve up that timeline and assign some responsibility other places in the hospital. So we've achieved that in our executive rounds. It's moved on from that, and Jackie will talk about where we've gone from there. But we're hoping the aim of it was to reduce unwanted variation, which we're all trying to, enhance the professional performance, improve the quality of our patients, quality of care we provide our patients, and to give some strong hard evidence to have conversations around. The report looks like this. It has quite a bit of information on it. It's currently in the process of being automated, but at the time it was a manual pull from the system, done every day by myself. It took me about an hour a day for each day that I had to do it. But it meant that when we had these conversations on executive rounds, that we actually had the right information. We knew where the issues lied, and we didn't make assumptions about things that happened the day before. So just for example, one of the major parts of it is that now we actually track how long it takes from request to consult in the ED to when the specialty comes and makes a decision in the emergency department, and the heads of department of each of the specialties all own those times and look at it daily. They send it out to their teams as well. So it's provided more than just a tool for the executive round. It's provided some opportunities for praise for teams. We've had often emails go out from heads of department to registrars saying thank you, you did well yesterday. We do not send out emails saying you didn't do well. We've started trending the data, and since we implemented it back in June, we've had some improvements. This is our medical specialty time from request to complete consult in the emergency department. There are a lot of ongoing challenges, especially when it comes to data, and we've mentioned a lot of that today. Automating the report is difficult at the moment because of the data feeds. Trending the data, knowing which information we want to trend, what's going to be meaningful to the clinicians, not to the executive. Adequate support to do that. Consistency of staff entering the data, because it's all dependent on people putting the information into the system when they're doing, making the phone call, pressing the button to say consult request. We can't, there's no way we can ever find the truth if we don't have the information entered in, so it's challenging. And so where to from here? I'm going to hand over to Jackie, who's going to talk about what the report has evolved into from just supporting that executive round and becoming a tool, and how she's using it in her emergency department.
Okay, thanks, Nat. I'm not actually going to talk to this slide just yet because I think it's important to understand how we really used the data that Nat gave us. So before this, her description of Groundhog Day for the exec rounds would be the best descriptor I could come up with. It was like a really unpleasant recurring nightmare where every single day I would get told, your department's doing a terrible job of ETP, and I would say, yes, but we've got all these patients. The medical team are averaging 6 hours to come see a patient. The surgical team don't answer their pager, and they'd say, yes, but your ETP's terrible. What's your fast track doing to fix that? And I'd go, right. And so one of the things that was really crucial that Nat's worked super hard on is making the information that the exec are looking at, that I'm looking at, that the inpatients are looking at, relevant. So that I don't get given information on how long it took for the wards to allocate a bed. I don't care. It's not my problem. That needs to go to the NUMs of each of the wards. I get information on what was the ETP for your fast track stream, what was the ETP for your acute stream, how long did your team take to make a referral. So one of the things we look at really closely is the time to referral, because when we first got that data, I have to say I was horrified. And when I showed it to my team, I think they were even more shocked than I was, because I at least had an inkling it wasn't going to be good, but it was so much worse than I ever imagined. When I take that information to my team and say, look, yesterday it was an average of 180 minutes from the time a patient arrived to the time you referred them to somebody. What on earth were you doing? And they'll say, oh, well, I took ages to see them. Okay, well, I've actually got that data too now, so thanks to Nat, I can now look at the time to be seen from when they're seen by the ED doctor to when they're referred. I can say, okay, well, that was 175 minutes, that's not a lot better. So being able to give that information to our team has been really, really powerful in us understanding what's really going on rather than what we thought was going on. But it's also been really powerful to be able to hand problems off that don't exist. So one of our big problems was that medical registrars particularly, although also the surgical, predominantly the medical registrars, their kind of theme for the day as to what the problem was in ED was that we refer all these people to them that are a waste of their time, that they don't have to see, that they discharge home. So Nat ran me a data report and it shows that 95% of the patients we refer get admitted. End of conversation, hasn't come up again. So really, really powerful to be able to debunk some of the myths about what was going on, both within my own team, because sometimes they thought they were doing a lot better than they were. But also with some of the other teams and saying, well, look, this is the reality. We've got evidence that shows you're taking 7 hours to respond, and we know it's because you're in theatre. We get it. You need to operate, but someone needs to answer the phone. So being able to get that information back to the specialty teams has been incredibly powerful. Their bosses were as horrified as I was with some of our data to see that it was taking 600 minutes for the surge team to turn up to see a patient from the time that we first tried to contact them. We've got an agreement with our inpatient team that the time we push the consult icon is the first time we try to contact you. It's not our fault it takes you 5 hours to get back to us. And so they were saying, oh, well, I came down 5 minutes after I spoke to them. Well, yeah, you did, but it took you 5 hours to talk to me. So we've got really good cooperation from our inpatient teams about what this data means, how we use it, and how we feed it back, and accountability, which has been an incredible thing to have. And the exec rounds now are starting to focus more on what can we change today, what can we help each other with today that's going to make a difference. The Where To from here has been a really interesting project. So I'm going to start, before I explain what this all is, I'm actually going to tell you that before we did any of this, we talked to our senior team. So I sat down with my senior team and I said, okay, I need to have a really honest conversation with you. I've got data about the performance of our team at an individual level. The question is, what am I going to do with it? So right at that time, I was the only one that had seen it, other than Nat, who'd generated it for me. And I spoke to my senior team and I said, so I asked you a while ago what were all the things that you thought were affecting performance, and you told me it was the number of patients we were seeing, it was the shortage of staff, it was how long the regs took to come, it was how many ambulances came in, how high our acuity was. I can tell you that Nat's run that data for me. Not one of those things is consistently related to the performance in ETP, not one of them. And my team looked at me and said, are you kidding? I said, here's the data. And they went, oh. I said, yes, when all of those or several of those happen together, the whole department falls apart. But we all know when those days happen. But it's not true to say that my day of the week is always busy or my shift was the busiest. Actually, when we looked at it, those things did not relate to ETP. So it was really important for my team to hear that there was something else going on. And I said, so what else could be going on? And one of my team said, and I must admit there might have been a little bit of prior conversation about how this was going to play out. One of my team said, well, is there something else going on? And I said, well, it looks as if it may be varying depending on the team that are running the department. And they kind of looked at me. And I said, so how do you feel about us looking at that? My team unanimously voted that what they wanted to know. What they said was, if I'm doing something different to someone else and it's meaning that the department's not performing well, I need to know that. So I got their permission before I actually used this data, and I think that's really crucial. I think if you use this data without your team's support and trust in you, you're going to do a huge amount of damage. So I got the data and I held on to it for a while, and I said to my team, tell me all the things that work that you do. Tell me the things you think you do that don't work. And I sent it out as a Google spreadsheet. Unbeknownst to me, one of my team, thinking I would read it more carefully than I clearly did, in the what doesn't work box actually wrote, hitting the registrars on the head with a hammer. And I didn't notice. And I sent it out with that still on there. But it was actually really important because we were trying to capture what doesn't work. And you know, look, standing there and telling your registrars or your juniors that they're not doing a good job and they're not working hard doesn't work. So we got the agreement from our senior team, and we then got the same agreement from our junior team. Now, what you can see here, obviously it's de-identified, is a screenshot of how many patients in a 10-hour shift our staff were seeing. And what you can see is there's some pretty significant information on there, isn't there? There's one very clear outlier. Now the question is, if that's just one day, there might be a really good reason for that. But what I've now got is data for a month. And actually what it shows is that we've got one outlier who is actually only seeing, on average, 3 patients a shift. So what I've done is I've gone back to that person and I've said, hey, let's have a chat. How can we teach you to do this better? So I didn't go back and say, you're a terrible junior doctor, you're doing nothing. Like, what is the problem? I went back to them and said, look, compared to everyone else, you're seeing less patients. How do I teach you and support you to see more patients in a shift? Because you're clearly not doing what everyone else is doing. So I think what's really important here is it's not about telling people they're doing something badly. It's about identifying people that need some support and reinforcing the people that are doing a really great job. And what's also really crucial is you can't do it shift by shift, and you need to understand the context. So a really good conversation I had with someone was, I can tell you that person did a terrible job yesterday. They only saw one patient. And I went, yes, sorry, and it wasn't Nat, by the way. And I said, yes, actually that was the medical registrar, and I don't expect them to see any patients in my department first up. So they actually had done us a favour and seen a patient as the first treating doctor. So that medical registrar actually did a fantastic job. And then there was someone who'd seen 14 patients, and I'm like, well, if they were in fast track, that's okay to poor. If they were in acutes, that's outstanding, but I'd actually be worried that they were doing a bad job. So it's really crucial that you understand the context of the data you're looking at, and that you don't just kind of randomly send it out to your team and expect them to understand it. What we can see from this as well is the ETP. You can see the time from triage to when they were seen, and that's probably a reflection of the busyness of the department and not so much the function of the doctor. But what is potentially a function of the doctor is the time to consult request. So you can see there's huge variability there between people that are seeing people and referring early and people that have a tendency to refer them late. And that was really important information for us to have. So what we've done is we've given that information to our senior team members, and we've said this doctor, on average, is taking a really long time to refer people. We need to keep a closer eye on them, and we need to support them better. What we're doing now, one of my consultants is working on it, is creating some benchmarking between our senior team. So what we've done is we've split it into the acute stream or the fast track stream, and they've got slightly different data. So it's the ETP for the acute stream, the average time to specialist referral or inpatient referral, and the length of stay for the acute stream patients that are not admitted. And that's because the not admitted acute stream patients are our responsibility in terms of their whole length of stay. And that actually for us includes anybody that would in other centres go to an ESA, because we don't have one. Our fast track stream, they're judged on their ETP and the did not waits, because we know that most of the did not waits come from the fast track stream. So the did not wait is a good indicator when the fast track stream is not keeping up with the flow of patients and maybe not utilising all the tools and strategies that we've put in place to manage that. And obviously they're the fast track length of stay. What we're doing with that information now, and we've just put it all together, is that there is a very clear pattern. And we kind of thought there would be, but nobody wants to be the pattern of the not performing team. So we've now got to be very, very careful how we give that information back to our team. And what we're doing is we're doing it one-on-one. We're discussing what they're doing well. We've taken that list of things that people said, well, this works and that doesn't work, and we're trying to share that information across the team. The other thing we're looking at is the time to specialist referral for individual doctors. So what that gives us a sense of is what's their processing, what's going on from the time they see a patient. Are they fluffing around? Are they actively making decisions? Are we supporting them? So if this is our junior doctors with a 120 minutes, that tells me we're not supporting them enough. That doesn't tell me they're a bad doctor, it tells me we're not there for them. So we're actually saying to our senior doctors, if you've got a junior doctor with a referral time that's that far out, that's actually your responsibility. It's not the responsibility of your junior doctor. It tells me you're not supervising them and supporting them. So probably a bit of a different attitude to what people might think we were going to do with this data. For the JMOs, what you can see there is the number of patients that they're seeing, and what this actually hasn't quite got yet, but what it will have is how many patients they're seeing per shift. So we can run this data, it's now part of the report, but it comes to me, it doesn't go out to my team. And again, it's about identifying who's performing really well so that I can go to them and say, what are you doing differently? Or I can go to the nurses and say, what's this individual doing that the rest of us are not doing? Because they're doing something that's working. The ongoing challenges, we do have some crossover of patients between streams, no matter how hard we try. So the data's not perfect, but we do know that it's close enough. It's close enough to make some really good decisions on. We don't have an ESSA, so that creates a huge problem for us. What we've asked for is, can we create an icon to make a consult request as if there was an ESSA, not because we want to identify the patients, although that's kind of helpful as well in terms of politically fighting for an ESSA, because we clearly need one, but it's actually so that we can tell the difference between somebody in our acute stream that's been there for hours, whether we've consciously decided to keep them there for hours and we're doing something, or whether we're fluffing around. Because at the moment we can't tell the difference in that group. I think the really important thing is this requires a huge amount of trust. So your team has to get this information from someone they trust. If a manager came in and gave the exact same information to my team that I did, it would be a very, very bad situation. You have to have the agreement of your team if you're even going to consider doing this, and you have to be very, very careful what you do with this information, because you can use it for really powerful change and you can use it to create harm. The other thing that we have an ongoing challenge with is that we're still very locum dependent. About 50% of my workforce in the medical stream is still locum based, which has enormous problems. So at the moment we're focusing on our senior team and benchmarking them to really bring home to them that they are responsible for the performance of every member of their team during their shift, and really making it clear that that's our expectation, which to some degree alleviates the variation in our medical workforce. And obviously our permanent staff are getting this feedback. So the take-home messages really from Nat and I is creating data that's useful and using it to empower positive change and to understand what's really going on. So debunking some of those myths, getting rid of some of the excuses, getting rid of some of the explanations, and then taking that data to the people that need to see it and saying, this is what's going on, how can you help me deal with it? Performance data requires trust from and between teams. So my team needs to trust me, but I need to trust the inpatient teams, and they need to be able to trust my team. So that when I see that a med-reg who I know is not in my unit right at that moment has clicked off that they've just seen a patient, I have the confidence that I can take that information back to the head of medicine and say, look, I saw this happen on the shift I was on. Please can you talk to your registrar? We're not about gaming the data. We're about using the data to understand what's going on. Is the med-reg truly unavailable? If they are, we need to look at that from a workforce point of view. Please explain to them that this data is not about punishing them. It's about knowing what's going on in our system and understanding it. Equally, if one of the inpatient teams comes to me and tells me that my team's been gaming it by clicking a consult icon when they haven't made any attempt at a consult, my team knows that I'm not going to take that very well, and that I'm going to be upset that they're making it difficult for us to actually improve things for our patients. Focusing really on what we're doing well in order to be able to replicate it. So making this a really positive use of data, not a punitive one. And using the data as supporting evidence when you do need to have a conversation. So like that JMO that was underperforming, being able to say, when they say to me, because they did, but I see way more patients than that. Well, here's the data, you don't. So how do we help you fix that? So really it's just about using the data for good, not evil. And making sure that your team knows why you're doing it and believes that that's what you're doing. And I really want to thank Nat for actually managing to make all of this possible, because before this, I had a fair idea what was going on, but some of it was a surprise even to me. But having the data every day to be able to empower these conversations so that I'm no longer justifying why the wards didn't allocate a bed, because that's not my problem. My problem is, what did the doctors do? Equally, my NUM is now responsible for the bit that her team are responsible for. It's made a massive difference to our department. Okay. Yeah.
I think that's fantastic. I know that a lot of us have dabbled in this a little bit, but this beauty of looking up and down and pushing up and down and done quite well. Fantastic, Jackie. I really...
Nat did the hard bit.
And Nat, do you like living where you live at the moment? Do you?
You can't have her.
Do we have any questions or comments from the floor? I think that was... I really love that, because I know that in our place, and my places move around a bit, have dabbled in this, but I don't think I've had the power of the data and used it wisely, which it sounds like you're doing very wisely.
I'm just wondering what specific tools you used to extract the data. So it came from FirstNet, and was there any specific tools that you could advise others?
Yeah. It came from about 5 different sources, and in particular in FirstNet, one of the 5, there was probably about 6 or 7 reports that I had to pull, and I literally just used an Excel spreadsheet and a little bit of Excel magic to produce it each day. Louise Kershaw is an advisor to the Whole of Health program, and she was the one who assisted me with it. We're looking at automating it now. We've got a performance unit called Spark that are working with me at the moment to automate it for our district, and because we share the same feed as South East and Sydney, probably it'll be available to them as well. But yeah, it comes from FirstNet, from the transfer of care reporting system, from Patient Flow Portal, because there's other data in there. Like, it's not just ED. That was the whole point, was that we'd have these conversations about ETP and only talk about ED, but yet there's so much of that journey that is outside of their circle of influence. So now, having the NUMs assigned a portion of that timeline, and the heads of department assigned a portion, patient flow assigned a portion, it sort of allows everyone to work on a little bit of their own patch, and has made them more engaged. So yeah, the information gets talked about at the HODS meeting and things like that. Yeah, so it's hard to pull it out, but I've now got it down to half an hour with an ED data clerk. They can do it every day. So.
No, that's impressive. One challenge that we have in our department, and I suspect everyone has it, is that doctors want to be doctors doing clinical work and not doing data entry. And I find that some of the quality of our data is quite variable depending on when some of the icons have been generated. And I imagine that you've found the quality of your data has improved as you've closed that communication loop. Have you noticed much of an impact?
Look, it has improved, but it was so horrendously bad to start with that I'm not sure we're not even close to where we'd like to be. Yeah, look, that's a huge problem for us. As you said, it's a problem for everybody. What we've done is we've tried to make sure that the information that we're pulling is actually information they would have to put in anyway. So we're making it as simple, as basic, as clear-cut as we can possibly make it. There's no data entry for the sake of data entry. So the data entry points we're using are all things you have to put into the system for various reasons anyway. And then also going back to the team and explaining why it's so important. It's not about making the inpatient teams look bad that they're not responding. It's about understanding what's going on and knowing where we're at and what we've done. So we are talking about this. We have sort of a two-hourly huddle where the nurse in charge and the doctor in charge of the acute stream chat about what's going on, and often they're the ones picking up when these data points haven't been entered and chasing them up. We're also discussing it on our handover round every day. We've created an SMO mobile computer that's got a communication book on it like the nurses have. And at the moment, things in our communication book is to talk about why the data points are important, why we're looking at this, and what the focus is for that week or so. And at the moment, the focus is really around timely referrals, talking to your seniors. Don't just sort of hide away in the corner and order a whole bunch of tests and hope we don't notice. Trying to get the juniors to feel really comfortable that we actually want them to come and talk to us. But no, we're not consistently getting those data points entered correctly. We've in fact we have completely abandoned the delay data entry because there's no definition across the state for what those data points mean. There was no validity whatsoever to what was in them. So we just said, look, that one's not useful to us. Don't even bother. Don't waste your time putting it in. Put the stuff in we really need. So yeah, it's about making sure the data's as clinically relevant as well as you possibly can make it.
Thank you for telling us about a really interesting project that's obviously very powerful data. My question was just, how do you mitigate against sort of there's a move towards just focusing on that data because that's what's easily collected rather than sort of on quality of care? You know, if people know, oh, everyone's just checking my numbers, I better make sure I refer. Someone had, very fast referral times.
Yeah, look, that's a really important thing. My staff would all tell you that I totally believe in ETP because it makes a difference to patient outcomes, and I do wholeheartedly believe that. They would also tell you that if a patient genuinely needs to be in the ED for longer than 4 hours and the ED team are the right team to look after them, then I expect that to be what's happening, and I will back them to the hilt when my exec come down and they have a go at me because one of my team kept someone there for 10 hours and my team member can tell me why, and I will back them to the hilt. There will never be a time where I will say you should have gone with the 4-hour target. Clinical care is always first. And we're really, really reinforcing with our team that we're looking at these data points not for the sake of data points, not to please the ministry and not to please my exec. We are looking at these data points because we know that if we provide the right care in a timely manner, our patients do better. So I think that's a really big part of the conversation, is making sure that every conversation is patient-focused, every conversation is quality-focused, and being really clear that this is not about gaming the data and that I don't care what the data looks like as long as we've done the right thing for the patient. Hopefully, the two marry up most of the time.
Just one question about the data integrity. We ran some FirstNet reports that showed number of patients per clinician, and we found that the same patients were appearing on 2, if not 3 clinicians' names for the same occasion of service due to handovers. So as soon as a doctor assigned themselves to the patient at handover, it came up as their patient as well in their numbers.
Yep.
How did you get around some of those problems that are built into FirstNet that we couldn't, without doing a whole lot of slog going through notes and finding out that patient was just being supervised by that particular ED physician on that shift?
Yep, so that was a huge problem, and Nat found some cool ways that I totally don't understand, and she tried to explain to me, my eyes kind of glazed over and I kind of went, I don't get it. So Nat has the answer to that, but what we also did was we ran a bunch of dummy runs. So we did, and we did it over quite a long 2 months probably, off and on, of trying different things. And the other week we had a challenge from one of our team saying, we think the handover is affecting it. So what we did was we intentionally handed over 2 patients using the 2 different handover possible techniques in EMR to doctors we knew were not clinically on shift in that 24 hours, so that if they showed up in the report it was really obvious, and they didn't. So we have fixed that bug, and Nat is the person that can explain how she did that. But as part of how you get all the data, there's ways of running the reports to eliminate that problem.
Yeah, I won't explain them, but you can email me. I'm totally
at the risk of everybody's eyes glazing over and hunger.
Well, all of us getting scared because she's so clever and understands it all.
Can I just ask a really quick thing? Really interesting project and a really amazing use of the data. And as you say, it's so important how you use it. Again, so going back to the breakdown of numbers, I guess there are limitations in any data collection. How are you measuring or accounting for sort of more management things that doctors or juniors may be doing in terms of reviewing other patients or looking at ECGs or asking all the kind of stuff that isn't captured very well by that data? Yep,
sorry, I didn't actually talk about that, but on this, on one of the slides it actually showed, and the data's terribly incomplete. This is one clear where I am having significant problems getting my team to do it, and it does look better than that. If we ran this report now, it would look better than this one. The last 2 columns of that, the SAS is our rapid assessment team, or our senior assessment streaming, whatever terminology you want to use. And that's when the senior team see a patient before they're picked up formally by somebody else, And the final column is senior medical officer review, which is where a senior doctor is actually reviewing a patient with a junior doctor after they've seen them. If you ran this now, most of the time you would see that our senior doctors have got a much better spread and a much more accurate representation of what they're doing. Still doesn't capture the kind of, glance at the VBG, glance at the ECI. It doesn't capture that, but we are working on the assumption that when we're looking at the data over a month, those things even out. Like, we would assume, probably fairly reasonably, that our senior team are doing much this. We only have one senior in each part of the department at any given time. So if you're acute stream, you're it. So we're assuming those things even out. So we've chosen not to track them because A, they'd be time consuming to track, but B, because we don't expect to see any variation amongst the team. But we are looking at the SAS and the senior review because that does vary from individual to individual.
I think this has piqued a lot of our interest, and hopefully the conversations will continue long into lunch.